Ladies and gentlemen, hello. So we are going to be talking about error and malpractice. Please do not leave. We will not be really giving to you the course on law. Nevertheless, we would like to remind you a couple of elements that are creating and that are part of the concepts related to error and malpractice, which is why I would like to give the floor to our colleague Audrey who is a lawyer, and she is basically specialized in this topic. So just in a couple of minutes, she will be reminding us a couple of components of these notions, and then we will go back to much more practical aspects, and we will be talking about professional practices, the rights of the patients, and questions related to communication and so on. So please, a couple of words about the error and malpractice. Yes, because these are two very different concepts, because, yes, indeed, the error, this is something that we're using very commonly. So this is the fact of making a mistake, a human mistake. So this goes back to this proverb that we all know, that the error is human, meaning that we can forgive it. So when does the error become a malpractice? And this is where we have the lawyers coming into play, because they have to transform this error into malpractice. And the judge will be making this qualification, because the error is part of the common things, whereas malpractice is a legal notion that is accepted by the judge and qualified by the judge. So the malpractice is basically a failure to exercise something that is a must, as it is a must, which a practitioner normally knows and should have respected. And the judge will focus, in order to define the existence of a malpractice, is basically something that can also cause liability, because liability is based on three important elements. First of all is harm and the link to the causation, and these are basically the elements that allow us to understand whether there is malpractice or not. So in order to orient the judge, we will be talking, first of all, about the obligation of means, which is the obligation of the medical practices, and then ask him or herself what are the means that were available to this or that practitioner in order to act in this precise case, because we cannot make something standardize or uniformize this malpractice. And in order to define this malpractice, basically, the judge will use the data that they know about, the data that is accessible to them, meaning the data about the medical practice, also the data from the science. This can be also protocols established by the scientific community, but also what is called the soft law. And the soft law, this is something that allows us to project this professional into the medical practice. So the judge can position themselves in saying that in the future, this is what we're going to do. So to see whether this or this professional in question actually did something, failed to do something, or did something that went against the rule and committed this malpractice. So we don't really have this strict definition. It actually is determined on a case-by-case basis, and we can have the question related to the diagnosis. But the question here is that whether it is actually a malpractice if the doctor does not establish the right diagnosis. We can say that the jurisdictions and the case laws are much more in favor of the petitions, because the clinical science that the patient could represent at that time could not allow the petitioner to establish a very certain diagnosis. Or probably another example, when the patient would come and they had problems at the level of their belly and some digestive problems, but also the headache, and the doctors weren't able to find what was that. And this was something that was not at all related to the clinical symptoms that the patient presented. So it was a torsion at the level of the testicles. So in the case where the diagnosis is not at all obvious, that's when we cannot make the doctor face liability, because with all the elements that were present, it was impossible to establish the right diagnosis. When the liability is here, whenever the doctor has to face liability, is when we have clear definitions, and for some reason the professional did not actually do it. Well, the liability can be also without malpractice. Can you please tell us what are we talking about here, so that we will be able to go back to these questions later on? Well, when we are talking about therapeutic hazard, that's what you are talking about right now. This is a concept that is based on the national solidarity, and this is something that we created in order to somehow compensate for all the damages that are related to the therapeutic hazard, to something that happened throughout all the treatment, because we can consider that there was no error or no malpractice here, but just the technique or the therapy that has been used shouldn't have led to the situation in which the patient found themselves. It actually is related to what Professor Éric Weber will tell us, and I would like to tell you that he is working with important pathologies because he's a liver surgeon, yes, and we would like to also talk about this innovative chair called BOPA at the APHP. So, Éric, you are basically working with very special and complex operations. So how does resonate with you what Audrey has just said, and how can you master all of this and make sure that you can somehow grant the safety to do all the interventions safely? Well, I believe that this is the problem of the definition, because we are talking about therapeutic hazard that is responsible of some negative effect or harm. So I believe that in certain cases we have to be courageous to say in certain cases that this is an important complication that happened after the surgery. So I believe that we actually are modifying our relationship to the error. Well, I am doing the liver surgery, so this is complicated surgery, and sometimes it also implies a lot of risks for a lot of patients. So we actually have to understand whether this was a good decision or not, because a lot of situations are new situations for us, situations that were unforeseen. So I believe that the true topic here is that with the surgeon community, we have to redefine what exactly is this error and what is the malpractice. Because for me, the definition is not exactly what you have just said, but for me, the error is a bad decision that has been taken once, whereas the malpractice, this is the bad decision that is taken over and over and over. So for me, from the point of view of surgery, that's what I see, because it's really terrible to see in some cases people who would be committing exactly the same malpractice many times. So yeah, well, the first time you believe that this will be like an error. Yeah, well, of course, but whenever we are talking about the unseen before situation, if you make a bad decision, this will be an error. But if you make this bad decision over and over and again, this will become malpractice. Well, I believe that we will let you react a little bit later, because I believe that you will have some things to tell that. Well, Éric CHENUT, sorry, you are the president of Mutualité Française, and we already know it very well. This is the organization that works with a lot of health professionals and so on. So you're basically presenting a citizen movement. How are you reacting at what has been just said? And do you think that there is probably a deeper dimension that will be a little bit different from the legal dimension and the dimension related to the mastering of quality? Do you believe that there is something that is also related to the consciousness of the health professionals and citizens? Yes, of course. I believe that if we would like to have this relationship between patients and caregivers, and this relationship to remain of good quality, we definitely need to establish trust. And here I go back to what Professor VIBERT has just said about the error and the malpractice. Well, this is probably the way that I see these topics. We are in this context when the democracy in the field of health has moved forward very much and progressed very much. Nevertheless, we still can move forward because we can share the knowledge even better, and the quantity of information sources also became less important, which is also a very good thing if it is well organized. And thanks to the mobilizations of patient associations and patient communities, we're able to share knowledge and share information. But it becomes really disastrous when people are getting the information on their own, in their own corner, and put the beliefs as well as the opinions at the same level as the knowledge. Well, here we can have something absolutely disastrous, because from the point of view of scientific culture, we cannot understand that on a certain number of topics, especially the topics that are very new, we are moving forward through error. And just to take an example to illustrate, this is what happened approximately 2 years ago at the very beginning of the health crisis of COVID-19. We were facing the virus that medical scientific community did not know about. So we were making decisions in the context of urgency, and these decisions were taken in the general, respecting the general interest. And little by little, we were learning things about this disease, and also correcting little by little as we move forward things with respect to the knowledge that we have accumulated, and we're learning new things. But we also have one part of opinion that has this impression that because things have evolved and the knowledge base has evolved also, they were lied to. And this is something that feeds into all the conspiracy theories of what we have lived through. I believe that we have to think over this situation to see how we can disseminate even better scientific culture. How can we support the patients and social insured people, because I believe that this is the link of trust itself that will be affected by all that I have just mentioned. And if we don't make a distinction between this approach and the truth, this is the capacity of living in a common world that is questioned here, because we're talking about doctors, patients, and media, and all of them will be talking about different things. And if we're talking about different things, we will not be able to understand each other, which is why these things are essential for us to create a society, but also to have a very serene relationship between doctors and patients. This morning, Mr. Kushner was talking about this law of 2004 that imposed information given to the patients. Well, we know that this is not something that is completely here in practice, and we will go back to it throughout our debate, but so that the patient would have a better understanding of all the risks or hazards, they have to be informed. I will not be asking you about this right now, because I believe that you still have a lot of potential, especially knowing all the insured people that you're working with, because you have the communication with them. But first of all, I would like to ask Jean-Pierre THIERRY, who is representing here France, Assos, Santé. So this is an association of health as well in France. How exactly do you see what Éric CHENUT has just presented, this relationship of trust that has to be here, and we will also see how it will work between the professionals and patients. How is it seen by the patient associations? Well, just to start, I would like to talk about the curative before even talking about preventive. So curative, this is a research to repair, which is legitimate for the patients or their families who believe that they are suffering from a certain harm. And of course, they would like to have a certain compensation and so on. So in France, we have the system that is quite positively perceived by the associations. So basically, we have many appeals. And we also have this appeal, I will be just briefly talking about it, about what is called ONIAM, which is National Medical Accident Compensation Board, that is here to compensate those who believe that they have some damages. So what I wanted to say is that we don't really have a lot of information about the volume of what is being repaired and compensated in France. Because with respect to ONIAM, the National Medical Accident Compensation Board, we have some numbers, some figures, and these figures come from the Conciliation and Compensation Commission, but we also understand that, of course, there are some errors here without even looking for malpractices and so on, because this will either be solved in an amicable way, or it will go through the insurance companies. We also have the phone line that is available here, and this is the service that is called Information and Law. And we also have some specialized associations that exist in this field. We have this ONIAM, National Medical Accident Compensation Board, and so on, that are here for that. And also, just to tell you, the ONIAM is also here to do some compensations on very specific topics that are related to mediation and so on. So basically, there are some special topics here. So this is approximately 200 million euros of expenses. So this is what I'm saying, curative. And now I would like to talk about preventive, not to monopolize time. We have many challenges. So all those who are participating in very difficult topics, which are the improvement of the safety of the patients and so on. So these are the agents in establishments. So we have a lot of factors and stakeholders who are here, and even an industrial branch can contribute to this. So just to describe a little bit, what are patients? In 1747, this is something that was happening every single time in the United States, and this is the report of medicine in 1747, and these are results that have been collected by Harvard Medical Practice Study, and they were talking about thousands of medical files in New York, but also in other states. So basically, they said that it was the rule of three, and this is quite something that can be criticized, and they said that this was something to calculate the death that could be avoided every single year in the United States. So medically, they said that this is basically the equivalent of one person who dies every single day. And they basically spoke about this phenomenon a little bit later, and just to tell you that WHO talked about it as well, and they took this same scheme in some Anglo-Saxon countries. They say if 10 hospitalized patients would suffer from a very acute disease, 1 out of 3 will die. So this was quite a phenomenon back then, and this is a diagnosis that has been established, saying that the system of care, healthcare, is not a very safe system, is not a very sure system. We have this repetition of the error. So it's basically systemic in terms of approach. So just to tell you, probably the drugs have exactly the same name, or probably you will have the surgery on the bad side of the body of the patient, or on the wrong body part, or probably there is a transition of the team, or probably there is an error of diagnosis, or probably not the right drug was administered to the right person, and so on. So in France, we actually did the small study, which was called NAES, and it actually had much less budget. And this is something that goes back to 2004 or 2019. But in 2019, the sample was so small, so they weren't really able to talk about the random character here, because some hospitals refused to participate, which is why we found 0 death. So for this rule of 3 that has been established in the United States, basically it was not verifiable anymore. But what WHO said, while taking this initiative, very important initiative with respect to the patients, is that, well, the challenge of the WHO this year, because the big day of the patients this year is this error, medication error. Starting from this day of the patient that happened quite recently, the medication error is something that we can prevent. So we can prevent this. We can avoid this. Yes, that's what I wanted to say. So this is basically why, when we are looking at the overall errors, if we can find one that represents approximately 30% of the total and can be corrected, well, if we are paying special attention here, we can basically avoid a lot of these errors. Well, I will not be really talking to you about all the methods because we don't have time for that. But just to tell you that the American study has been re-examined quite badly, somewhere approximately at 2016, and they were talking 56,000 to 200,000 deaths per year. And this was part of the medical magazine, and the methodology was quite questionable here. They said that this was the second cause of the mortality. Well, the WHO said that it was the third cause. Well, that's what I wanted to go back to today. Well, the medical error that can be avoided. This is between the third and the 10th cause of death in terms of epidemiology. So when we are looking at all the articles that have been published talking about the causes of death, this does not appear enough. Well, nevertheless, these are the figures coming from the United States that you have just mentioned. Well, worldwide figures, I would say, but we actually have to be careful while considering the conditions of getting these figures, because this also depends on each establishment that is providing care and a lot of different factors as well. But I believe that right now it's important for us to look into the future, because the question is about tomorrow, patient tomorrow. So somehow in the background we can talk about the figures that we had at the very beginning, but what can we do in order to improve this in a sensitive way and in a sustainable way, and what are the ways and methods that different stakeholders can implement in order to have an improvement with this. So, Éric, I would like to talk about the PHP right now, and I would like you to explain us how does this work, and this is the innovative chair BOPA that you are working on. So how does it work, and what is the progress here with respect to the safety of the patients? Well, the innovative chair BOPA has been created 2 years ago approximately in order to try and improve the safety of the patients in the operation ward. Well, our goal here was to have together the human approach and the technological approach, meaning that not to work only on the surgeon, but on the whole operation ward, together with the anesthetist and also all the staff members that are working right next to anesthetist and to the surgeon. This is something that we have created all together, and it actually is funded thanks to the sponsors that we have. We have the Foundation Paris-Saclay, Telecom, and P. And the goal behind this is to evaluate whether the technologies that consist in filming everything that we are doing, because I believe that the topic here is basically the problem of the relationship to the reality. And today we are analyzing everything that is happening in the operation ward throughout the summaries of the operation, but this is the interpretation of the reality by those who have lived it through. So if we have some errors that are done there, it's pretty much possible that someone did not understand that they made an error. So the background problem here is to see how we were able to make sure to all of the colleagues working there that they have to think about their way of perceiving information, gathering this information and then using this information to the best end, so that to not create any negative impact. Because if every time someone can do something and they are very scared to do this, they will never do anything, and it will basically create a huge hurdle. So this actually brings us back to the problem related to error and malpractice, because we have to admit that it is through error that we can discover new things. So I can tell you that tatin made with some penicillin, this will be an error. But the topic here is to ask ourselves this question: how will we be able to do this, and whether this will work? Now, I believe that in order to go precisely into the problems related to the liver surgery, well, yes, of course, the death rate in the benchmark that has been created right recently shows that it's approximately 30% of death rate at 3 months after this surgery, with the easiest cases of disease. So 13%, that's quite a lot. So yeah, I was talking to you about the complexity of your surgery. Yeah, these are quite heavy diseases. So I believe that the topic is basically something that will go through the planning, meaning the simulations, high fidelity simulations with digital twins that will be anatomic, functional, and very well done. And they will be here in order to inform all the stakeholders working in the operation ward. So this will be something to create tools that will allow us to have the flight plan, I would say, just to take this comparison of everything that will happen in the operation ward, so that to allow the surgeon to do the surgery with all the people who will be right next to him or her, with everyone who is well informed about what they will be using how they will be using, and so on. And if there will be a situation that is unexpected, they will have to have some help. That will be either digital or also coming from the telespectry, from the surgical telespectry. And this is something that is not very much developed in France yet, but this is very interesting. So the goal here is to really be able to plan and to inform all the stakeholders and to have this operation plan, surgery plan for the unpredictable situation and be able to get help either from the computer or from another human. So this is basically the approach that is technical, but at the same time managerial. And I would like to go back to Éric in order to continue this discussion that we have started a little while ago. So we have the second dimension, which is the way of interacting with the patient. And all the debates this morning already said that probably we are not communicating enough with patients and probably we're not explaining enough what we are doing to the patient. So how do you see this? Because you have, well, with respect to what you have said previously, and in the movement that you have 35,000 insured people, do you think that this is a culturation phenomenon or no? And also, with respect to this acculturation that is necessary and information and also learning that can happen here so that to make sure that the patients will be probably a little bit less aggressive because they are informed and because they're conscious of the difficulty, of the risks and of consequences. So how can we manage all of this in a rational and practical scenario? Well, we can try and play our role of mediators in our relationship with our members of the insurance company. Well, right now we are offering services, so it's part of our contract, but we also have this role of education and training for the citizens to explain to them how the health system works, but also how the relationship between patient and doctor can happen. And in this sense, it is essential, and a lot of insurance companies do this through their publications or articles, through internet or newsletters that they are sending to their members, and I believe that we still have a lot to improve in this sense throughout the journey that can be also very much supported by the digital tools. We can also use data in order to provide the right information upstream, like how Dr. VIBERT can inform all of his team, the team that is working in the operation ward. It's also important to inform the patient about what is going to happen, meaning to step down to the level of the patient and give them all the necessary information for their level, because it's necessary to be informed. We have developed, for example, a protocol with Gustavo on the announcement of cancer. So this is the program of the whole phases after the announcement, the creation of the protocol, and so on. And beyond the correct presentation and the gain of time for the patient, the fact that the patient knows what will happen in the upcoming weeks grants us a better level of understanding and acceptance, and reassurance is much better. So throughout this mediation, this explanations, this providing information, basically, we are accepting the patients as they are, meaning a responsible adult, someone who can understand, and we are allowing them to play this role. But we also allow them to interact in a more calm way with the doctor, because they were able to think about a lot of things, think about a lot of questions that they would like to ask, and so on. And I believe that this is fundamental. But there is also another element that I believe that we have to think about collectively, is the way for our society to think about and to tackle the principle of precaution, because it means that we shouldn't have any hazards. But if we have any hazards, we will not be moving forward, and this will be the society that will collapse. So with this respect, we really have a true topic. We have to explain what is this principle of precaution, and we don't have to say here what it does not represent. Either we're talking about the therapeutic hazard or the error. Of course, that there has to be a compensation compensation if the patient has been harmed or something like that, but we don't have to go and look for a malpractice when we don't have it, because we not always have a malpractice when there was a hazard or when there was an error. That's what you have been saying back some time ago. And we also have today a part of population that really wants to go and look for someone who will be liable, who really wants to go looking for malpractice and so on. But I believe that this is really a bad approach, and this is a losing approach for us. So we really collectively have to pay a lot of attention here. So the principle of precaution, we will actually do something very nice for Guy, because we have been criticizing a lot the principle of precaution. So Audrey, for the principle of precaution, in terms of therapeutic hazard especially, and in other terms also, how do judges interpret this? Is there some constraint for the judges by the legal texts, meaning constitutions and so on, but probably case laws as well? How does this happen, and how do you see the evolution related to the principle of precaution? Well, I actually see it much more on the societal side, the side of society, the evolution with respect to the acceptance of the risk and of this hazard. And what I also can see from the patients is that a lot of patients believe that they are informed because they have this access to the data online, and there is also this popularization of medical information. So they basically refuse the concept of error, and they start thinking there is a malpractice, the malpractice was committed. And also, well, I believe that for me, the difficulty is basically the lack of communication that exists, and this is what we can see throughout all the trials and cases. So just to go back to very concrete cases, let's say there is a patient who would like to complain against one of the health professionals, and they are going to the disciplinary instances, and this is medical deontology as well, and there is the consultation. So they have to first of all meet each other and talk about this problem, talk also about the quality of relationship and care and so on. And generally at this very stage there is a very important shift that happens, but it actually has to be both the patient and the doctor must be very well prepared for this stage, because very often this is also an awareness that appears on the side of the doctor that probably the patient did not interpret well what the doctor said, and it actually allows us to deal with the conflict very quickly, and the patient can accept this hazard. But if there is no communication, well, they will refuse the hazard, and they would be inclined to continue and to look for this liability. So this is a choice that we have in the administrative law, in civil law, but also in criminal law. So we have to, right now the patients are looking for this liability, and they will go and see the doctor probably because the doctor was going quickly and did not provide enough explanation, or probably the establishment did not create the mediation procedures, did not offer all of this in order to make the patient understand how the care was organized and that the other care wouldn't have changed anything. So I believe that on this point, this is completely fundamental. We have to change the mindsets and find this trust, the trust between the doctor and the patient. Éric? I believe that we still have a couple of minutes left. I would like to ask you the question before you will take the floor. So at the patient of tomorrow, if you were tomorrow in this situation, so what would you do in order to guarantee, on one hand, the safety of the patient, but also in the very operational and concrete way to make sure that there will be these questions about the relationship of the patient and the medical bodies would be improved in terms of the trust. So what will be this new law of 2004? Well, I will be mostly addressing the intelligence of people, because I believe that people, well, it actually can have consequences, and it can encourage people as well. I believe that they are not stupid. They are all intelligent, the patients, I mean. And I believe that we have to do something that will come from the medical information to the medical knowledge. I have developed applications, and it's been years and years ago, in the field of the liver surgery in order to explain to the patients, to the sick. And unfortunately, they're very little used. So right now we are trying to evaluate how come confirms that the situation is so. So we have to use the intelligence of people, but we also have to explain to them the principle of uncertainty, because I'm an expert of the surgery of liver, but I don't really know a lot of things about the liver cancer. And some of situations I would like to say, I don't know what to do there. But I'm a specialist, so it's actually important for people to understand that medicine, healthcare, this is not an exact science, and that's what we lived through with COVID. Sometimes we are getting to the limits of the knowledge, and there, either we do nothing or we make a decision, and then we have to face the consequences. Jean-Pierre, the very first decision of the Minister of Health, in order to modernize the law of 2004. Well, I believe that revolution of prevention of the safety of the patient, that's very, very important, because there will be always this curative part of the compensation, because some people are really feeling bad and everything like that. But I would like to go back to the systemic character of undesirable events. We have a toolkit that is here to sort it out, and the patient is waiting for it to be improved. And I believe that a lot of people are contributing to this because they are publishing a lot of things and so on. There is an international experience also, and we will have to talk about it a day, because we did not do this rule of three. Who knows INES and the three parts of INES that are part of the Ministry of Health website? Well, approximately no one. Well, this is the topic that we would like to evacuate, because we have one of the best health systems in the world. We already understand it. Now, we also have the margins in order to be able to work with the therapeutic hazard, especially if this is something that can be avoided. And we sent you back to the toolkit. And I actually came into this field because one of the first measures that has been foreseen starting from the 2000s, from the years 2000, it was this quick win. It was something that would allow us to give the drugs and so on. And this was this led to the decrease of 50% of the medication error, of the technical therapeutic hazard and so on. And it actually takes quite a lot of time. Well, I believe that it actually will allow us to decrease the medication error, and this is once again the aim of the WHO at the international level. And there's a lot of countries that are much more exposed to this than us, the developing countries, for instance. But this is the worldwide goal of the WHO. They would like to have the medical error decrease 50% by 2050. And to go back to the relationship between the caregivers and patients, well, first of all, I would like to go to the study NAs, and only 6% of all the events that are declared in the study NAs were declared on the website of the Ministry of Health. And this is the same thing in the United States. We understand that the curative will not allow to have this culture of safety in the establishment. So we have the strategy of the culture of safety that will also represent the interest of patient and of the doctor, because the medical error can be avoidable, because in most of establishments this will be the second victim of the professional of health. And in France we actually like to point our finger, and this is why all these errors are not declared, do not appear, because we have this moral and sociological way. Probably this will be too much, but this is the fault, and this is the fault of the leadership, first of all. Éric, CHENUT? Well, three important elements. First of all, work with national education and the Ministry of Superior Studies, graduate, postgraduate studies, and so on. This is how we will be able to win and to progress in terms of understanding. Second, a better sharing of information. And three, the systematization of the mediatization tools. I believe that this is absolutely necessary whenever something happens, to make sure that the stakeholders, meaning the patient, family, the caregiver, and the establishment, they have to talk, they have to have discussions, exchange, understand each other, so that to understand and to avoid possible conflicts and so on. Because mediation is a great tool, but exchange of practices among the establishments of health that also are not always satisfying the understanding of the clients. They have to evolve, evolve their information system, and to avoid all sorts of frustration, conflicts and difficulties in the future. Just one word, probably from you, Audrey. Yes, I believe that we have to accept the error and make the best of the consequences. Thank you to all the four of you. Thank you.